Thanks, Kathleen. It's really an honor to be here to present our work. I'm speaking here on behalf of myself and Isaac Alatishe. Isaac's name is up there. Isaac is my co-investigator and now dear friend who is a consultant surgeon in Nigeria. And before I start, I also need to wave a little bit more of the flag that Kathleen mentioned. As one of the surgeons who's involved in global oncology, I like to always stress that I think you cannot have a conversation about cancer care in low middle income countries without having surgeons at the table and really having a leadership role at the table. It's not obvious, but for instance, in sub-Saharan Africa, in the majority of countries, there are no medical oncologists that treat solid tumors. There are no radiation oncologists. If you have breast cancer, cervical cancer, colorectal cancer, gastric cancer, any of these diseases, when you present, a surgeon does your biopsy, a surgeon operates on you, a surgeon writes for your chemotherapy, a surgeon takes care of all the complications of chemotherapy, and you never see any other physician. So to have conversations about this without a surgeon at the table, I think is really, there's an empty chair that has to be filled. So I'm going to talk about colorectal cancer screening and why it's important, how it's used in the US, how it can be applied to low resource settings, and where do we go from here. These are data from the US in 2015 that were recently published. So colon and rectal cancer are the third most common in males and females. And when you look at estimated deaths, also third most common. So it's pretty well known in the US that colorectal cancer is a major problem. It is one of the unique diseases where there are screening mechanisms that have been proven to be successful. I list here some of the studies that have been done. Actually, Bernard Levin is here with us. He's been one of the leaders in this throughout his career. But it's a unique disease because with colonoscopy, for example, adenomatous polyps can be removed, and this reduces the incidence of cancer and also allows for diagnosis of colorectal cancer at earlier stages, and this reduces mortality. There's been huge prospective studies that have all proven that screening for polyps and cancer, and there's a variety of methods, whether or not it's fecal-based testing combined with sigmoidoscopy or colonoscopy, can reduce colorectal cancer mortality. And this is even long-term results after initial screening. And it's also been proven to be cost-effective. So where we start with colorectal cancer is there is a huge amount of evidence and data that show that screening can be successful. So how is it used in the US? Well, we have very clear guidelines that screening is recommended for average risk patients, men and women, over the age of 50. But despite all of these data, despite all of these randomized trials, compliance still remains suboptimal. At least a third of Americans, it's estimated, do not participate in colorectal cancer screening. And my colleagues in Nigeria are fighting to get colonoscopy approved for their new government insurance system. And they cannot believe when I tell them, we may go through this whole argument and have colonoscopy approved, but a large part of your population still won't take advantage of it. And they can't believe that there are Americans who have an opportunity to be screened that don't take advantage of it. And that's for average risk patients. Then there are high risk patients who also still don't get screened. So these data are for relatives of a patient who's been diagnosed with colorectal cancer. If your relative was diagnosed at less than 45 years of age, you have a 10% cumulative incidence of developing colorectal cancer. So even in these patient populations, high-risk families, screening often is not complete. And the barriers to screening in the US have been studied and are somewhat obvious. So it's inconvenient. Nobody enjoys a bowel prep. Nobody likes taking half a day off of work to do the bowel prep and then the next day off to have a colonoscopy done. It can be uncomfortable. Here we usually do it with conscious sedation. The colonoscopy in Nigeria is done with 2 or 3 milligrams of Versed. The patient is basically awake, and when you get extremely uncomfortable, you get a little bit more Versed. So while a little bit uncomfortable here, outside of the US, it's often very uncomfortable. There's also a real lack of information in many communities in the US about risk for colorectal cancer, about the screening tests, about what can happen if you screen positive, and there's a lack of access. The population that's been studied the most, that declines colonoscopy the most, is African American patients, especially male African Americans. And there's a question of there being a higher incidence of colorectal cancer in this group, and it's really unclear whether or not this is access to care and delaying diagnosis, or this is a true difference in incidence. But clearly this is a high-risk group. And in reading through all the studies about why African American males often do not get colonoscopies, often it's stuff like we've heard in the last few talks. Lack of understanding, the doctor didn't explain this to me, I didn't feel this was important. And patients report little knowledge about colorectal cancer in general and have a real fear of the healthcare system. There are some successful studies in the US that have overcome some of these barriers. This is from my hometown in New York. This is out of Lincoln Hospital, which is one of the large public hospitals in the Bronx. And they identified the African-American male community especially as a high-risk group. And they utilized patient navigators. They streamlined the referral network so that if you were diagnosed with a colorectal cancer, there was a direct line in to gastroenterologists and to surgeons. They made guidelines for referrals at all their community health centers, and they had a simplified fact sheet just to explain to patients why they were being screened and what a positive screening meant. And their results with what looked like fairly small interventions was really a drastic drop in the amount of patients that missed their appointments. And because this was a high-risk group, there were a high number, 25%, that had abnormal findings. And overall, 2% of their patients were diagnosed with colorectal cancer. So it is possible to overcome these barriers. Now, how can this be applied to low-resource settings? These are worldwide data, which also show colorectal cancer is the top 2 or 3 when you look at incidence and when you look at deaths. So clearly, this is an important problem. And while not traditionally thought of as a problem in low-income countries, the rates are rising drastically. And I got interested in this topic about 5 or 6 years ago when Isaac and I were going back and forth between each other's institutions. And we realized that half of his ward was filled with colorectal cancer patients, yet nobody talks about colorectal cancer in Africa. And the more general surgeons that I spoke to over there, this was a recurring theme. So we originally started this as Kathleen mentioned, a colorectal cancer consortium. And just 3 weeks ago, we actually changed our name, kept the acronym because the acronym has stuck. So we're now the African Research Group for Oncology because we've broadened out from colorectal cancer. But we really started with the idea that there was a big disparity in care and outcomes between patients with colorectal cancer in West Africa and here in the US. So we started with a goal of improving training, research, and treatment to improve outcomes and to try and bump the survival curves a little bit closer together. I'm not showing them here, but the survival curves, one goes across for the US and one goes straight down for Nigeria. A really drastic difference. And this is where all of this was generated. This is ward rounds. This is a patient with colorectal cancer. The majority of patients there present with, at times, visibly obvious colorectal cancer, which is not something we think about in the US, where tumors are, you can physically see them, either protruding through the abdominal wall or out the rectum. And this was a clinically generated question of how can we figure out who even gets colorectal cancer? There are no prospective data for all of sub-Saharan Africa on colorectal cancer. There are a lot of retrospective studies that we and others have done looking at data that is generated in hospitals, just looking at hospital records. But we wanted to figure out prospectively who gets this. So we teamed up with 5 hospitals, Isaac's hospital and 4 others, and my hospital, Sloan-Kettering, and we made this consortium, and we got an NCI pilot grant that has helped us build a prospective database and a tissue bank. So we have 3 Nigerian researchers, a physician, a nurse, and a data manager. And we just accrued our 162nd patient yesterday. And this is about a 30-page questionnaire we have to get all demographic data, treatment data, outcome data, blood, and pathology, and radiology. And we've been able to bank all of this, and I'll show you some of the results that we have. So we're also interested in what are the outcomes of these patients. So we've been following them over the last year and a half to figure out where are we starting at baseline with someone with colorectal cancer. We've also branched out into breast cancer, and we're asking the question, can patients with breast cancer be identified earlier? And we're starting some community-based studies on screening. And how can breast cancer care be standardized? So you saw the Breast Global Health Initiative guidelines, and the guidelines are fantastic. The implementation is what the problem is. And Ben Anderson couldn't make it, but he's the first to say that making the guidelines, we were successful. Implementing them is really the challenge. So we're working on implementing a set of these guidelines just within 5 hospitals, because if we can't do this at 5 hospitals where everyone knows each other, then I think it's not going to work at a larger scale. So research is one of our focuses, and there's a lot of overlap between our goals here. Training is another one. So we've had 3 postgraduate courses that have focused on colorectal cancer and general cancer care and research. We have our first junior faculty member from Nigeria enrolled in a master's in clinical research course at Cornell, which is across the street from us. And he's going to be leading our breast cancer initiatives when he goes back. We have something called the Sudavar Fellowship, and this is a 3-month observership that we use to bring junior faculty from West Africa to Sloan-Kettering. They can't scrub on cases, but they come to the operating room, they make rounds, they're in our research conferences, they sit with our database managers, and this is how we've sort of built a cadre of junior investigators. Also, within our consortium, we offer a pilot grant every year, and this is to stimulate our investigators to try and get some pilot grants and some background data to apply for larger grants. This year, Isaac is applying for a K award. The NCI and NIH are now supporting low and middle income country investigators. So we're eager to try and get his research career to the next level. And we're doing a lot of training in pathology because you can't talk about surgery and cancer without talking about pathology. They're one and the same. And the pathology department there's about 4 attending pathologists and some technologists. They have a very hard time really fixing the tissues in a way that we can use them to do basic stuff like immunohistochemistry. So our pathologists at Sloan-Kettering, there's a Nigerian pathologist in the UK, Leeds, who's part of our group, have done training modules for them to try and improve pathology outcomes. And the third focus of Argo is treatment. And one question we've asked is, can patients with colorectal cancer be identified at earlier stages? And I'll get into it in the next few slides about a colonoscopy study that we're partway through. We've also developed Argo standard operating procedures for colorectal cancer. And our hope now that once we hit our 200th patient is when our planned analysis is, and then we have a baseline set of data. And then we're going to initiate some therapeutic trials that are based on chemotherapy and surgery to see if we can improve some of the outcomes that are extremely poor currently. And in breast cancer for treatment, one of the studies that we're starting this winter is early discharge after breast surgery, which sounds fairly basic, but actually this is a major issue. And what they identified is that they keep patients 10 days after a mastectomy to take care of wounds and to take care of the drain that we leave. In the US, on day 2 or day 3, you go home with drain training, you empty your drain at home. 10 days later, you come back and you take the drain out. One of their major problems is they have so many women with breast cancer that there's a massive backlog of beds. And so oftentimes they're turning women away because they don't have an available bed for them because the wards are filled with patients who are sitting around getting drain care. So we're going to start a trial to try and demonstrate that it is safe in their environment to send patients home with drain training, which should free up a lot of bed space. Our postgraduate courses have been very successful. Our first one had about 20 people in a cafeteria, and our last one, which was this past spring, had about 120 Nigerian physicians from all throughout Nigeria. And this was a masterclass in colorectal cancer and a national consortium meeting, and a lot of our research has been generated out of the relationships that have come from these meetings. And there's been a few serendipitous developments that I never anticipated. This is one of them. This is the disease management team that was created. So this was a few weeks ago when I was in Nigeria, and this is a radiologist, a pathologist, and the surgeon sitting in a room talking about all the patients with colorectal cancer, going through the films and the pathology and the surgery, updating the database, and talking about what the next steps in care are. This didn't happen even a year ago. We didn't plan for this to happen. They saw this, our team approach at Sloan-Kettering, and said, well, we have the same individuals. Why can't we do this? So now every month there's a disease management team conference. And here's what our data is showing. So the median age of presentation is 55. This is about 15 years younger than you find in the US. 56% were male. The majority had blood in their stool. 23% had obvious bleeding for more than 6 months. Most had weight loss. Rectal cancer was the most common, and the majority of patients presented with metastatic disease. The survival is extremely poor. There's not a cancer in the US that we talk about 6-month survival at, and their 6-month survival was 62%. The 1-year survival was 48%. So this is quite drastic, and this is our starting point, and we need to generate these data so we know moving forward with our therapeutic studies, how are we improving this at all? So how do we decrease this mortality rate? Prevention, screening, and improving treatment. Prevention, there are lifestyle changes that can be initiated. Screening, one would be to prevent colorectal cancer or diagnose it at an earlier stage. And for the members of the research group that we have right now, what I've circled around here is really what we're focused on. So we looked back at Isaac's colonoscopy data for the past, from 2007 to 2011, and we looked at who had bleeding from the rectum and who had colorectal cancer, and we tried to figure out how can we identify a high-risk group, because it's unrealistic to think that everyone over 50 or over 45 in Nigeria is going to have a colonoscopy. Both financially and logistically, it's not going to happen. So we're trying to identify a very high-risk group. And we eventually sort of settled on over 45 with rectal bleeding. We did think about using stool-based studies. That's the most economical way to do this. There's a lot of cultural resistance for patients to do stool-based studies at home. The physicians and community health workers don't think that it's gonna be practical. And there's also a high prevalence of benign rectal bleeding, which would complicate this, and we would have to scope a lot of patients that don't have cancer. In fact, the majority of patients wouldn't. So we've done this prospective study. We started with a 100-patient trial with all patients over 45 with rectal bleeding. That was over a week. And we had exclusion criteria for some patients that could have reasons to have bleeding or would be high risk for colorectal cancer. When we did these 100 patients, we found 58% were male. Age was 58%, was 58. And most patients had 6 months of rectal bleeding. Almost everyone had seen a doctor over that 6 months with rectal bleeding, most diagnosed with hemorrhoids. Usually the first stop before the physician is a traditional healer who treats with antibiotics or herbs. And then after that, a community health physician. So people had actually been accessing the healthcare system, but had never been referred in with the question of colorectal cancer. And one of the reasons why is because 71% of these patients had hemorrhoids. So it's very common to think rectal bleeding, you have hemorrhoids, here's your explanation. But obviously you can have hemorrhoids and cancer in the same patient. Diverticulosis was actually very common, which is not thought to be accurate. This is not thought to exist in sub-Saharan Africa. Polyps were also very common. Also not supposed to be very common in sub-Saharan Africa. A lot of the reason I think is because this hasn't been studied rigorously prospectively. And 20% of these patients were diagnosed with colorectal cancer. This is a very high number. There's no way 20% of all patients over 45 with rectal bleeding in the whole country have cancer. There's clearly a selection that's happening here on how these patients make it to us, but this was a very high number. So we took these 100 patients and we tried to make a predictive model that we could then test in 3 other cities with 225 more patients about how to identify these high-risk patients. And this uses a point system. So these are patients over 45 with rectal bleeding. That's the screen. And then have they had weight loss, change in stool, and you get points, and there's a probability for colorectal cancer. We did that with cancer and with polyps. A useless model would have a C-index of 0.5. Ours for cancer was 0.895. For polyps was 0.71. That's off of just 100 patients. We're about 150 patients into the 225 validation set at 3 other cities, so we wanted to be in a geographically different area. And in just a quick look at the data, it seems like the numbers are almost exactly the same. About 20% of the patients have colorectal cancer. So where do we go from here? What we're working on is still overcoming many of these barriers. So there's a financial barrier. In Lagos, it costs $1,000 for a colonoscopy. That's totally impractical for 99.9% of the population. In the city that we're working in, Ile-Ife, it costs about $100, which still is pretty impractical. There is now a government-run insurance system that takes care of about 15, maybe 20% of the population, and our hope is that this is covered with that and that insurance plans grow. Access to care is something we're also studying. Where can patients get colonoscopy? Training is something that is obviously vital here. Isaac is one of the leading endoscopists as a surgeon. Most of the surgeons do the colonoscopies there. So they have a huge training center, and he runs courses throughout Nigeria. And a large part of this has to be education and cultural acceptance. There's a Yoruba term, jedi jedi, which sort of covers everything perirectal and anal. So if you have itching, hemorrhoids, colorectal cancer, it's one word that describes everything. And I got Isaac a New York Yankees jersey that says Professor Jetty Jetty on the back, because he's now known as Dr. Jetty Jetty. And anyone who has anything perirectal, perianal shows up at Isaac's hospital because we do television spots and radio spots and talk about rectal bleeding and try and improve education around the importance of addressing rectal bleeding. But probably most importantly is going to be developing screening tests that work in low-resource environments. We don't currently have this. And myself and others are working on ideas about testing other things. So whether it's a stool-based test, blood-based test, that's, I think, going to be the key, because the barriers to screening large percentage of this population with colonoscopy are so massive, it's hard to think that colonoscopy is going to be the answer for most low and middle income countries. So this was at our meeting 2 weeks ago. All the work that I'm talking about and all these ideas are really born out of this group. This is the 5 hospitals in Nigeria and my hospital, Sloan-Kettering. And the majority of the people in this picture are surgeons, and then mixed in with us are pathologists and radiologists. And it's really, this is sort of the trifecta that we've made, because as I mentioned, for solid tumors, these are the people that are treating patients with cancer. And this is where all the, I think that all the research and clinical questions should come from. And this is Isaac and myself with one of our colorectal cancer survivors. This gentleman was diagnosed 2 years ago with stage 2 cancer, and he's become one of our advocates. It's been talked about a lot in breast cancer, the need to develop advocates and for community awareness. In colon cancer, the theory there is if you have colon cancer, don't go to the hospital because you're going to die, because as you saw from the survival curves, that's pretty much true. And until we identify more patients like him who have earlier stages and have survived, it's going to take a long time until patients are willing to come into the hospital even to accept treatment. So as one of our early advocates, he helps us with community relations, and we're hoping that there's a much larger cadre of similar patients in the future. Thank you.